And I know in your presentation you hinted at the role of TROP2 directed therapies in the future. What are your thoughts with regards to that?
Yeah, I mean, I think that trope two is a target we should think about, we should pay attention to. I don't feel totally done with it. I don't think the field feels totally done with it. You know, in trials, we know that we have other trope two targeting agents. I talked about datopotamab deruxtecan. I talked about sacituzumab tirumotecan, which are two drugs that were recently presented at ASCO GU in phase 1 and have shown some responses and some safety in a preliminary phase 1 study. I mean, this is early, but the target remains of interest. And if I'm completely honest, sacituzumab govitecan remains in NCCN as an other regimen. And when we have those patients who have had platinum doublet after EV pembro and don't have anything actionable on their next gen sequencing, and maybe you've tried some other kind of single agent chemotherapy from trying to be cost effective and you don't have something else, like I still rarely order it on occasion for those patients. And so, again, I don't think it's a preferred regimen. It's not preferred by NCCN. It's not preferred by me, but I do think that there's a role for very select patients still.
Absolutely. And I think it was interesting that you highlighted also that some of the variant histologies have a higher TROP2 expression. There's probably an unmet role somewhere about using some of these agents. And you brought up an interesting point about the role of platinum-based chemotherapy and what to do in the second line setting. What are some of your thoughts? What is your practice? And what is the role of immunotherapy rechallenge in your practice?
Great. Oh man, great questions for all of us. And I know you think about them, I think about them. I don't have the answers. When someone is progressing on EV pembro, and ultimately, even though I think I started this chat with my rose-colored glasses on, and I usually have them on as an oncologist, but I think there's the opportunity for cure, and the reality is that most patients aren't going to be cured, and most patients, even if they have a great response in the beginning, will end up having progression of their disease. And what do we do after that? I think that platinum doublet chemotherapy was the mainstay for so long and still does have a role. We have as much data to use that in the second line as anything. We created a vacuum, and so it's up to us to try to piece together some data as to what to do next. There was a great abstract at ASCO from the MSK group about, real world data, over 200 patients that they gave platinum doublet chemotherapy to after EV pembro. The majority got carbo, but some got cis, and they were seeing response rates around 50%. I think that is exciting to know that, when we talk about single agent chemotherapy with response rates around 14%, we know that erdafitinib in patients who have an FGFR3 is what, 40%? So 50% is really encouraging as an unselected therapy, like a not target selected therapy. And so I think it is as good as anything. And the problem is most patients aren't going to be cisplatin eligible post EV as far as neuropathy goes. So I envision, and at least in my practice, most patients are going to be getting carboplatin and gemcitabine. So I think that that's an excellent choice versus clinical trial. The problem is most of our clinical trials are written in a way where a patient needs some prior exposure to platinum before eligibility, whether that's in a neoadjuvant setting, sort of short order prior to progression to metastatic disease, or in the metastatic setting. You asked
Yeah.
me a second part, but I forgot it.
Yes. The second part is what are your thoughts on immunotherapy rechallenge?
Yeah, I know people are kind of, when you do platinum doublet chemotherapy, I think it is an unanswered question. I don't fault the people who are doing maintenance of avelumab after that. I think that that remains a question, but it's a data-free zone, right? Maintenance of avelumab. So how do you judge that? Because that was given to patients who had stable disease or better. So I guess this is you give your 4 to 6 cycles and you have stable disease or better. I just struggle with, am I going to give you some infusion reactions, or I'm going to give you a 3 hour drive to Atlanta every 2 weeks,
Right.
and that's both ways, right? And they're making it in a 1 day trip without clear benefit to me.
Right.
So
Right.
I'm
Right.
not, but I think people are. And I think in a data-free zone, we have the latitude to make those two different decisions, is what I'll say. I Open question.
Right, absolutely. And where do you see the biggest evidence gaps as far as performance status, neuropathy, perioperative therapy, and then progression to metastatic disease?
So okay, one by
And
one.
variant histology as well, I guess.
Variant histology. It is only a gap. Like we
Yeah.
only have a gap. We have really good data I think from Andrea Paulo's group with regard to immunotherapy and cabozantinib, but those are small trials and sort of variant rare histologies. We have retrospective data from the UNITE study about the prevalence of these biomarkers, whether it's Nectin-4, whether it's PD-L1, on the surfaces of variant histologies. And yet at the same time, we know that it is so much, responses are so much more complex than what is the Nectin-4, H score. And we don't even check that clinically when using this drug anyway, enfortumab vedotin. So I think a lot remains to be done. We have a study open at Emory, which is an IIT open here and will be opening at MSK shortly because it's difficult to enroll to, which is EV Pembro in variant histologies. And so it allows any variant histology with the exception of neuroendocrine. And so hopefully, I mean, it's small, it's a goal enrollment of 25, and it's going to be a mixed cohort, which is obviously the problem with variant rare studies, is that you're enrolling everybody who has those rare diseases, and then you just have a couple of each. But hopefully that'll give us some signal as to responses in some of those. So I think more to come on that. Number two was neuropathy. Oy, I mean, I think we have to look for our antibody drug conjugates that are not going to be worsening that are not conjugated to MMAE. Maybe they're
Right.
conjugated to a topo one.
Right.
They're going to have their own profile, but it's going to be really challenging to give MMAE after MMAE to most patients. And so I think that'll kind of direct where we go from here.